Hello, all. After a long break, we are back here to discuss a very important topic, a topic that helps us understand why our body is no less than a soldier and how, when, and what it does to safeguard us against pathogens and foreign elements. We are here to discuss inflammation. To make this huge topic simple, I have divided it into three videos. In this video, we'll discuss about the definition of inflammation and acute inflammation. In the next video, we'll discuss about the mediators of inflammation. And in the last video, we'll discuss about chronic inflammation and tissue repair. And as always, questions, doubts and healthy discussions are always welcome in the comment section below because knowledge shared is wisdom gained. So let's go. So before we move on to what are the cardinal signs that inflammation causes in our body, it is important to understand what leads to inflammation. To understand this concept, let us look at this image. So as you can see here, we have certain unwanted microbes or foreign bodies which enter our body through a barrier called as the epithelium. Now as soon as it enters our body, it is recognized by certain cells called as macrophages, dendritic cells and mast cells. As soon as they recognize these unwanted elements, they release certain cytokines or the mediators which enter into the blood vessel. Now, as soon as they enter into the blood vessel, they recruit four major types of cells. One is monocytes, the other is granulocytes, the third is plasma proteins and the fourth is platelets. These have two major actions. They eliminate the microbe or the dead tissue by recruiting cytokines, growth factors and extracellular membrane proteins which lead to repair of the tissue. The other is they will cause vasodilation or increased vascular permeability which lead to edema. Now these lead to the cardinal signs of inflammation which are calor or heat, rubor or redness, tumor or swelling, dolor or pain and functionolasa or loss of function. Before we move on to acute inflammation in detail, it is important to understand the differences between acute and chronic inflammation. In acute inflammation, the time course is of rapid onset but it is short-lived, whereas in chronic inflammation, it is of a much more slower onset but it is more long-lived. The predominant cell type in acute inflammation is a neutrophil, whereas in chronic inflammation, it is macrophages and T lymphocytes. The nature of response in acute inflammation is physiological. In chronic inflammation, it is almost always pathological. It's a mild tissue injury which resolves quickly when in case of acute inflammation. In chronic inflammation, the tissue damage is more severe and more progressive because it is of a slower onset but the course is more long-lived than acute inflammation. Now let us start the most important and the most elaborate topic of pathology, acute inflammation. Acute inflammation can be defined as the response of a vascularized tissue that delivers molecules of host defense from circulation to the site of infection and cell damage, which will lead to elimination of the offending agent. Are you confused? So was I. Let me simplify this entire definition to you in the forthcoming slides. To simplify that very complicated definition that I just told you, let us divide the entire acute inflammation into two events. One that occurs in the blood vessel, which are called as vascular events, and one which the particular cell will have to undergo, which is called as cellular events. Vascular events can be divided into vasodilation, increased vascular permeability, and leukocyte release. And cellular events can be divided into margination and rolling, adhesion to the endothelium and diapedesis. Am I making it more complicated for you? Let me simplify this even further in the forthcoming slides. Normally what happens in a blood vessel is that there are two opposing forces, as you can see here, called as the hydrostatic pressure and the colloid osmotic pressure. Now these two maintain a steady flow or laminar flow of the plasma proteins. The earliest change that you see in acute inflammation is vasodilation that usually occurs due to histamine release. Now this vasodilation will then lead to increase in the intraendothelial or interendothelial spaces, which will then lead to increased concentration of RBCs, which will result in an increase in viscosity and that would lead to an increase in stasis. This is then followed by increased vascular permeability, which will lead to an increased hydrostatic pressure, and decrease in the colloid osmotic pressure, and that will lead to formation of exudate due to fluid and protein leakage. Whenever there is a leakage of only fluid and not the plasma protein, that would lead to formation of what you call as transudate. To understand exudate and transudate better, let us look at this flow chart. So exudate occurs because of an increased vascular permeability like I have mentioned before, and transudate is only consisting of ultrafiltrate of plasma. This occurs because of increased hydrostatic pressure and there is normal vascular permeability. Exudate is seen in conditions like congestive cardiac failure and transudate is seen in conditions like pus. Since exudate contains plasma as well as proteins, the appearance will be purulent or hemorrhagic with a yellow to red color. Whereas since there is only ultrafiltrate of plasma like you have seen here in transudate, the color will be straw colored and the appearance will be clear or serous. The protein content is obviously high in exudate and it is low in a transudate, and even if it's there, there is mainly albumin. The specific gravity is more in an exudate and less in a transudate. Clot formation, it occurs because of high fibrinogen level. There is no fibrinogen in transudate, so it is absent. Bacteria is always present in exudate, not in transudate. The cell count is always high in an exudate and low in a transudate. The type of cells will be neutrophils in acute and lymphocytes in a chronic inflammation in exudate, and there will be only few lymphocytes and mesothelial cells in transudate. The LDH or the lactate dehydrogenase content is very high in exudate and low in transudate. The type of edema will be non-pitting edema in an exudate and pitting type in a transudate. Normally, there is a laminar flow of the plasma proteins with leukocytes, which is usually surrounded by endothelium. Followed by the contraction of endothelium due to histamine release, there are two types of response that are usually present: immediately for 15 minutes and delayed in case of burns or toxins that usually occurs after hours. This will lead to endothelial cell injury and that would lead to necrosis and detachment. After learning about how the blood vessel responds to a particular pathogen and what is the inflammatory response that it elicits, we'll now come to the cellular events of inflammation, in which we'll discuss about how a cell leaves its host and comes to the site of injury during inflammation. This is governed by three major processes. The first, we have margination, which usually occurs when the leukocytes come close to the endothelium. The next process is rolling, in which there is slowing down of the leukocyte to help them attach to the endothelium. And the third, we have diapedesis or migration, that usually occurs when the leukocytes exit the endothelium and enter to the site of injury. To further elaborate on the cellular events of inflammation, let us start by understanding the role of selectins. Selectins usually aid in the rolling of cells. There are three types of selectins: L-selectin, that is usually expressed in the leukocytes, E-selectin, which is expressed in the endothelium, and P-selectin, which is expressed in the platelets. This P-selectin is stored in the Weber pellet bodies. Now what happens is, whenever an injury occurs, there is secretion of cytokines like TNF and IL-1, which will stimulate the selectins and that will aid in the rolling of the cell. We now understood what is the role of selectins in inflammation. Let us try to understand what is the role of integrins in inflammation. Normally, leukocytes have the integrin in a low affinity state. The cytokines that I previously mentioned, TNF and IL-1, they will stimulate the integrin expression in the endothelium. Now you must remember that every integrin has a ligand for itself. Like for example, the ligand for beta-1 integrin VLA4 is VCAM1 and the ligand for beta-2 integrin VLA4 is ICAM1. So what these two is, they will activate the chemokines. So there will be conversion of the integrin from a low affinity state to a high affinity state, which will help the leukocytes to stop rolling and that will adhere itself to the endothelium. Following rolling and adhesion, the last step is transmigration and diapedesis. This will help the leukocyte to extravasate or to escape the endothelium and then go to the site of inflammation or injury. This is brought about by a molecule called PCAM1 or CD31. Now you must remember that this chemotaxis is brought about by chemoattractants. These chemoattractants can be endogenous or it can be exogenous. Exogenous chemoattractants are bacterial products and endogenous chemoattractants are cytokines like IL-8, complements especially C5a and arachidonic acid metabolites. After transmigration and diapedesis, it is now time for our inflammatory cells to go and attack the offending agent. But you must remember that these inflammatory cells do not come at one shot. There are phases to it. So as you can see here in these pictures and in this graph, firstly there is acute inflammation that occurs which is brought about by neutrophils. Neutrophils are usually seen in the site of injury in the first 6 to 24 hours. And since they are acute, that means they will arrive first, but they are the ones with the shortest half-life. So they will undergo apoptosis very fast. In the next 24 to 48 hours, you will see monocytes and lymphocytes. Now this is true for almost all the types of injuries except in cases like pseudomonas wherein there is only neutrophil which is predominant, in any viral infection which is lymphocyte predominant, and in any allergic reactions eosinophils will be prominent. After transmigration and diapedesis, we will now understand how our soldiers eliminate the enemies or the offending agent by the process of phagocytosis. Phagocytosis has three major processes. The first is recognition and attachment of the particular microbe to the phagocyte with the help of receptors from the phagocyte. This will then lead to engulfment of the microbe into the phagocyte. Now this is then aided by the lysosome and enzymes which will attach to the phagosome and the ingested microbe, and this will totally form the phagolysosome. This is then followed by killing and degradation of the particular microbe inside the phagolysosome. To further elaborate on the process of phagocytosis, it is important to understand what leukocyte activation means. Now, leukocyte activation is nothing but activating the particular leukocyte to recognize the phagosome or the microbe. Now, these have three major components. One is recognition of the microbes and mediators. The next is response which is elicited by the particular leukocyte. And the third is outcomes of that particular response. There are four major receptors that govern this leukocyte activation. The first is G protein coupled receptors, the next is toll-like receptors, the third is cytokine receptors, and the fourth are phagocytic receptors. We will discuss in detail what each of these receptors do. Now, G protein coupled receptors recognize three major components. The first is N-formyl methionine peptides, the second are chemokines, and the third are lipid mediators. Now, once they recognize and attach to these particular components, there will be cytoskeletal changes and signal transduction. That will lead to increased integrin avidity and chemotaxis. Increased integrin avidity, as we discussed before, is conversion of the low affinity integrins to high affinity integrins. What will that lead to? Adhesion of the endothelium. The second is chemotaxis. Now, what happens in chemotaxis? There is migration of that particular leukocyte into the tissues. The second is toll-like receptors which recognize microbes, and we also have cytokine receptors which recognize cytokines like IF and gamma. Now what these two do is they will release mediators of inflammation like arachidonic acid metabolites and cytokines, and they will produce reactive oxygen species or lysosomal enzyme. Now what do mediators of inflammation do? They will amplify the inflammatory reaction. Now this will be discussed in detail in the next video. There is also, like I said, production of the reactive oxygen species and the lysosomal enzymes, and there is also phagocytosis of the microbe into the phagosome which is brought about by the phagocytic receptor. Now that will lead to microbicidal activity of leukocyte, that is, like we discussed before, they will also call the lysosomes and the enzymes, and they will form the phagolysosome which will lead to killing of the microbes. Phagocytosis is incomplete without understanding about the role of ROS, which is reactive oxygen species, and RNS, which is reactive nitrogen species. What happens? Let us go one by one. We first start with reactive oxygen species. Have a look at this diagram. Now, as you can see here, there is a cytoplasmic oxidase which will go and bind to the membrane oxidase, and this will activate active oxidase. So this active oxidase will convert the NADPH into NADP+. Now what will that lead to? It will lead to generation of O2. O2 will then lead to generation of O2 minus. O2 minus is a superoxide. Okay. Now that will lead to conversion of H2O2, which is hydrogen peroxide, into OCl minus. Please remember this H2O2 to OCl minus. This is now brought about by MPO, which is a primary granule in the neutrophils, and this will also be added along with chloride. So this entire system H2O2, OCl minus and MPO, this is a H2O2 MPO halide system, which is the most powerful bactericidal system. This is very powerful and that will eliminate bacteria. Now as you can see here, H2O2 along with Fe2 plus will also generate OH minus. OH minus is also a powerful destructive agent, and this H2O2, Fe2 plus and OH minus is a Fenton reaction. So we have, I'll repeat, we have two major systems which will ensure that the bacteria are killed. One is conversion of the H2O2 to OCl minus along with the MPO with Cl minus. This is called as the H2O2 MPO halide system, which is a powerful bactericidal agent. H2O2 will also generate the OH minus along with the Fe2 plus, and that is called as the Fenton reaction. Now coming to the role of the reactive nitrogen species, it is important to understand there are three important reactive nitrogen species. One is eNOS or the endothelial NOS, one is the nNOS or the neuronal NOS, and one is the iNOS or the inducible NOS. iNOS is important for the phagocytosis of the particular microbe. What happens? Basically, there is a stimulus of the inflammatory condition, that is, there is entry of the microbe, and that will generate macrophages, that will generate your iNOS. What will that do? That will lead to NO plus O2. Okay, that will lead to ONOO minus. Now this ONOO minus is very similar to the reactive oxygen species in eliminating the particular microbe.